So what I'm going to do is I'm just going to go ahead and start this session, which is titled as Income and Health Inequality. So we've got 4 papers which seem very interesting. This is very much along the line of work that I currently do as well. So we're just going to start with Brijesh. So he's going to be the first presenter. Right, so the title of the paper is Nature of Health Insurance Demand in India. So you have 15 minutes, Brijesh. Please go ahead and take the floor. Thank you. Is Brijesh here? Okay.
So one minute, I just go back to what I start presenting, and I have it here, the screen, which is the so I have it here. The what I want to present is.
Do you want to share your screen?
Pardon?
So maybe go to the. There we go.
Are you able to see that screen?
Yes. Yes.
Okay, that's great. And let me now. Can I start the presentation?
Yes, please go ahead.
Okay, thank you very much. So I have it here, the presentation, which is Nature of Health Insurance in India. So are you able to hear me, please? Hello? Hello?
Yes, I am. Yes.
Okay.
Please go ahead.
Thank you. This is the topic on which I want to present today, and this is the nature of health insurance demand in India. Now, what we want to do is that this is in this study we make an attempt to explore elasticity of health insurance demand in India, because both the central and state governments have been trying to help people through their budgetary policies and government-sponsored health insurance schemes. So therefore, we want to see how it works in rural and urban areas and what is the elasticity. Keeping in view their effort and rural-urban disparities in the country, we have tried to make an attempt to evaluate whether the people have been provided appropriate information about these governmental policies. And second objective is to see that how the other socioeconomic factors are influencing the individual household choices to adopt a particular type of health insurance scheme. Now, so this is based on what we have used. The data is the National Health Insurance Survey. That is the National Health Insurance Survey is so we have the NFHS, which provides health insurance demand for rural and urban areas. And at the same time, it also provides data for aggregate level using households as unit. And using that data, we are applying a logic model, which results indicate that both in rural and urban areas, these efforts have helped people to adopt suitable alternatives. Now, how these have, and the results also indicate that the socioeconomic factors and rising levels of income in urban areas relatively to rural areas have been reflected in more responsive nature of choices for different health insurance schemes. Whereas by contrast, though the impact of these factors is also significant in rural areas, but with a lower elasticity of demand for healthcare insurance. But our exercise is limited to utilization as viewed from NFHS 4 conducted for 15-16. It actually, the survey conducted was based on 6 lakh plus households, and around the same number of women and 1 lakh plus men in that household, and therefore this is limited to those that survey. Now, the we have the literature review first, which is the I just quickly tell you what is the main literature which is existing in the theoretical studies area. The arrow is celebrated 163. He said it's a merit public good healthcare and it should be provided by the government. But the Poly said in 68 that moral hazard, that means that it is provided free of cost or subsidized cost, then people will try to use more. That is the moral hazard. So there are studies, but later on, the arrow also said, no, it is taken into both the demand supply constraints, then this moral hazard will not be there. And many more studies were in that duration. In 70, there were many more, but the Jack Hauser in 70, he looked at, there are some studies which are on the demand side, some studies are which are on the supply side. So Jack Hauser was 1970, which looked at from the demand side. And there was another study with Newman, which is the 2003, which contradicted moral hazard since it is primarily an income transfer effect. So with that, the main emphasis of these the what is the optimal insurance plan is that it should be here it should be offered to satisfy risk averse individuals without the problem of either moral hazard or supplier induced demand, because due to different reimbursement systems like fee for service or others, which has been talked in many studies, or others which allow cream skimming of insured patients. That means they try to enroll only provide care to them and those are insured patients, so that is the cream that is they'll get the money more from there. So that is the cream skimming. So from there, these main theoretical findings, I go to the some of the empirical studies. So the main thing is that besides theoretical literature, there are some empirical studies in both developing and developed countries, which also throw light on methods of health insurance, which were adopted to finance health insurance to all, and the various socioeconomic determinants which could be considered for different gender and occupation, which could be considered gender occupation groups in a nation, and which intends to provide coverage to everybody. So these are the issues discussed in the empirical studies. Now, main studies, for instance, Abu Bakr, he did 2012 for Malaysia. Another review literature was done by Anita Ho in 2015, and she has talked about various types of system. One is one risk, national risk pool and publicly provided services. This could be one mechanism. This study has been done by Logo Marcino et al. In 2012. And this there could be also mechanism by which they can provide insurance to all, like the system of Australia, Canada, UK, Thailand, or separate levies that is also discussed by Dotin Cham et al. 2010. And so model also are like them, like China, which mandates urban employers and employees of the state. Hello.
Hi, Brijesh. Hi, I just want to inform you that you have 7 minutes.
7 minutes, no problem. I will cover. Okay. The models may be like China, which mandates urban employers and employees of state-owned or private enterprises to contribute to the insurance program at the municipal level. That is, so there are some other methods which are models also, which include voluntary and private health insurance and community-based health insurance. So I have just given you an eye view of the theoretical and empirical literature. So I go to now the and thus these empirical studies provide us the inputs regarding suitability of health insurance model according to tax-based and government subsidized or finance model, or employer-employees based self-finance model. So in the Indian context, both the models of choices in health insurance are estimated by us using a logic framework, methodology, and data set from NFSS survey 4, which I already mentioned. So theoretical, whichever type of system is adopted, preferred choice of a consumer will depend upon his marginal utility in healthy and sick states, and actually fair premium charged by public or private insurer. So if you take theoretical schematic presentation, an individual may have a probability pi of being sick and 1 minus pi of remaining healthy, where pi lies between 0 to 1, and cost of treatment, for instance, is fixed value m, and he receives an insurance which is I, which lies between 0 to m, and therefore the individual earns an exogenously given gross income y, and derives utility uy from disposable income. So it is assumed that the individual is risk averse, or u dash y is greater than 0 and u double dash y is less than less than 0. And if the individual is healthy, disposable income is y minus p. And so y minus p minus what insurance premium he pays, what is the medical expenditure he incurs, and what is the insurance he gets. So this is the y minus p. He has disposable income. With sickness, it is ys, y minus p minus m plus I. And the expected utility of individual is given by EU, and then the individual presumed to maximize expected utility. Conditional demand for health insurance can be specified given that I upon y equal to 1 is then it's a function of pi, yi, ei, where E is a vector of individual's household and community variables, and I is the choice of health insurance provider taking binary values. So I equal to 0 if no insurance, or without any kind of reimbursement. So with this model, so we have I is a function of P, Y, H, E. H is health status, E is the other variables, set of factors, and the Y is the income, and P is the premium. So it is unobserved initial endowments. With this kind of model, however, the utility, so we finally, including other factors, we include gender, region, rural, urban, religion, caste, distance, and quality. So all these and our set of regressions with some of all these factors we have tried with or without, along with or without income. So thus using the inputs from above theoretical studies, the following, so we incorporate logic to capture these factors, and so we have estimated, as told earlier, that this is the survey, port in the NFH, and we explore the dynamics of health insurance using this, and therefore, and it provides the health insurance plan as a dependent variable. It is analyzed using basic socioeconomic variables, which include income, wealth index, sex of individual, age, and education level. We also consider rural or urban location of individuals by segregating into urban rural population covered in NFH survey. So with that, as already said, we explore the demand for insurance. Hello. Yes,
I just want to inform that you have less than 3 minutes. Sorry.
Hello. Hey, I couldn't get. Hello.
Just wanted to inform you that you have less than 3 minutes.
Oh, no problem. I'm just coming to an end. Okay. So from there we have derived the elasticity, average elasticity, and therefore the 4 set of elasticities were estimated, and that is below for the BPL, below BPL population, above BPL population, educated, uneducated, and educated population, and the rural and urban areas separately. So therefore we have analyzed for any health insurance, ESIS and CGHS, SHS. So 6 insurance we have analyzed. That is a SHI state health insurance, RSBY Rashtriya Swasthya Bima Yojana, community health insurance, CHI, PHI public private health insurance, and any other insurance which is not included in these categories. So the results we have it here. Looking at the results of rural areas, we observe that the choice of availing public or private insurance are also influenced by liking or convenient place of treatment as well as education level of respondents. This probably denotes the impact of increasing awareness in rural areas about different types of health insurance schemes. Second is the rural areas also seem to be making decisions about state-sponsored schemes like SHI and the RSBY, which are chosen based upon their age or wealth index. So these results at the state level, we also two states we consider separately, Odisha and Tamil Nadu, and they are not too conclusive, but aggregate level they show like that. And except for three types of insurance mechanism, like namely medical reimbursement to employers, other privately purchased insurance, and other insurance, elasticity coefficient rural area is less than 1. But in the above three categories, observed elasticity coefficients are higher than 1 across aggregate level, and Odisha as well as Tamil Nadu state level. So further results of urban areas, both at the aggregate individual state level, also indicate responsive nature of above mentioned three categories of health insurance. Thus, overall, our results suggest more elastic response, both in rural and urban areas, supporting a promising role of insurance markets in times to come. So with that, I am through. So we have that can be our which permits now. We have just already I have just covered all these things, and so so with that I am through with that. Okay. Any questions now? It can be open for the question.
So what we're going to do is we'll have the Q&A session towards the end, right? So just so it'll be like a combined Q&A for all of the papers that we're discussing. Thank you so much, Brijesh, for a lovely presentation here. We have another paper from Rajendra, Dulal, Shankar Ghimire Kul Kapri. The title of the paper is Causes of Socioeconomic Inequality in Nepal, Evidence from a Panel Study. So please take the floor, Rajendra.
Okay, thank you, Vinish. It looks like...
Okay, I just switch off. Okay.
Okay.
Audio.
Okay, can you see? Can I've shared?
You are viewing.
Vinish, can you see the screen I've shared?
Yes, it's there. Yes.
Okay. Thank you again, Vinish, Dr. Bohra, and the entire team for this opportunity. My topic today is causes of socioeconomic inequality in Nepal, and I have other two co-authors, Kul Kapri and Shankar Ghimire. Our questions are simple. Is there any differences in earning between male and female? Gender discrimination in earning? Similarly, is there any difference in earning between Dalit and non-Dalit? Difference in earning between different ethnic groups? We also are interested in capturing what are the causes of these differences. Is this because of some observable characteristics like education and training, or maybe it has to do with some unobservable characteristics or potential discrimination, okay? So motivation, at the beginning of Panchayat regime, Panchayat system, the state legally abolished discrimination, hierarchy, caste-based discrimination, ethnic-based discrimination, religion-based discrimination, with the new Muliki in 1963. And since then, especially in the last 3-4 decades, Nepal has gone through substantial political and social transformation. Restoration of democracy, multi-party system in 1990s, similarly, popular movement in April 2006 that turned Nepal into secular state, republic state. And the recent, the promulgation of new constitution by Constitution Assembly in 2015 that divided Nepal into 7 different provinces, states. More women are participating in mainstream politics and social movement. The same is true for different ethnic groups. But there is one domain where there is still potential discrimination is economic opportunity. Now, I'm not discussing in detail here the literature review here, but is lack of empirical study that captures disparity, potential discrimination in labor market in Nepal. This research seeks to capture gender-wise discrimination, ethnic disparity in Nepalese labor market. Now, data, we had the data from Nepal Living Standard Survey, household survey, and as we know, these are conducted by Central Bureau of Statistics in partnership with World Bank, and it has a rich data set both at individual levels and household level. At individual level, it has data on education level, income, gender, sex, health status. At household level, it has data on household size, household head characteristics, income. It also has data on geographical characteristics. Our focus here is on individual level panel data. Method, we use descriptive statistics, a random effect regression model. For random effect regression model, our dependent variable is log of annual wage. We also have some, for labor market outcome, dummy dependent variable, labor force participation, employment, and salary employment. Basically, labor force participation implies someone is either currently employed or actively looking for a job. Employment implies here is someone is working at least 1 hour per week during the time of interview. And salary employment refers to employed in formal sector or in full-time job. So for those these dummy dependent variable, we use panel probit model. And we want to dive deep into what are the causes of these differences. For that, we use Oaxaca blinder decomposition. As we know that Oaxaca blinder decomposes the differences into explained and unexplained components. So explained component can be attributed to observable characteristics, unexplained can be attributed to unobservable characteristics, and it can capture a discrimination also. For example, I have this equation for Dalit and non-Dalit wage equation, and we are interested to capture or understand the factor that determine the difference in wage between non-Dalit and Dalit. Okay, with that information, I have the results, which is the summary statistics. And as you can see, the annual wage is approximately 55,000. 70% of the sample are employed. The labor force participation is 70%. Only 28% of the people from the sample are employed in formal sector. Majority of them are female. Dalit ethnicity, approximately 7% of the sample mix are Dalit. So 37 are Janjati, and so on. You can see on the right-hand side, the characteristics of household head. And interestingly, or not surprisingly, less than 5% of household has female as head, right? Household head. And 85% of the sample, most of the sample is rural, from rural area, 85%, and so on. The next I have is the result from random effect regression model. So my dependent variable again here is okay. So education is positively associated with the annual wage, which is not surprising, right? Because this is the log dependent variable. So in terms of the number, it means that one additional year of schooling or education is associated with 13.54% increase in annual salary. And when it comes to ethnicity, ethnicity too means Dalit, which is not surprisingly negatively associated with annual wage. That means, in terms of the number again, on average, Dalit earns 37.5% is less than so-called upper classes, Bound, Kshatriya, and Newar. Female is negatively but not statistically associated with annual wage. Another variable of interest is ruler. Ruler is negatively but not statistically significantly associated with the annual wage. The next one is I have the result from Probit model, and for three different dependent variable here: labor force participation, employment, and salary employment. And as expected, education is positively associated with all of these variables.
Just wanted to inform that you have less than 5 minutes. Thank you.
Okay, great, Vinish, thank you. Ethnicity, when it comes to ethnicity, Dalit, ethnicity too means Dalit. So Dalit is positively associated with labor force participation and employment. But when it comes to formal job sector, it is negatively associated with salary employment. What does that mean is Dalit on average has a higher probability working in part-time job or insecure job sector, and they have significantly lower probability of working in formal sector compared to Bound, Kshatriya, and Newar. And female, when it comes to female, we don't see significant effect. For ruler, has a similar effect. Let me change this. So people from rural area compared to urban, they have a high positive relationship with the labor force participation and employment, and negatively associated with salary employment. Again, this implies that people from rural area, they work in part-time job or on informal sector, but their probability of being employed in formal sector is significantly lower compared to people from urban areas. Now, the next thing is we want to dive deep into find the causes of these differences with Oaxaca blinder decomposition, okay? The first one is Oaxaca blinder decomposition between male and female. And as you can see, annual wage is not significant. There's no significant difference in annual wage between male and female, between male and female in labor force participation and employment also. But when it comes to salary employment, you can see there is significant difference in earning between male and female, which is, we can see in terms of number, 0.104. Now, what are the causes of that differences? With the Oaxaca blinder decomposition, you can see the large fraction of that difference can be attributed to observable characteristics, as explained component contributes to more than 95% of that difference. What does that mean? And within that observable characteristic, I don't have the table for that, but education is the single big contributor for that difference. A small yet significant difference can be contributed to unexplained, unobservable characteristics, which means there is some potential discrimination against female in formal job market. Now let's see the same difference between Bound, Kshatriya, and Newar and Dalit. When it comes to Dalit, so there is, you see, negative difference in labor force participation, negative difference in employment. And there are positive discrimination against Dalit in labor force participation and employment. But when it again comes in the formal job sector, there is significant positive difference between Bound, Kshatriya, Newar, and Dalit. And also, you can see large fraction of that differences in salary employment can be attributed to a difference in observable characteristics. And of a small fraction of that can be attributed to discrimination against Dalit. Now, we also have the Oaxaca decomposition result for urban versus rural, which is similar as Dalit. You can see labor force participation and employment. There are negative differences. So discrimination in favor of rural areas. So people from rural area, they tend to work more in informal sector, private part-time job. But when it comes to salary job employment or full-time employment, there is discrimination, there's differences in earning between or probability of being employed in formal sector between rural areas and urban areas. And I have the policy implication of this. So when it comes to explain differences, which has to do with the observable characteristics, education is the main driver. That means program. Okay, Vinish, you have something?
Yes, we're almost to the very end of your presentation. If you could please wrap up.
This is the last slide. Okay, so the program on policy to address the gap in education attainment between male and female, Dalit and non-Dalit. And when it comes to unexplained difference, which has to do with the unobservable characteristics, there is potential discrimination. So it has to be addressed from more political and socially inclusive society. Thank you. This is all I have.
Thank you so much, Dr. Dulal, for your interesting insights in terms of causes of discrimination, or causes of socioeconomic inequality in Nepal. So we're going to do the Q&A session towards the very end. Now we have the third presentation. So we have Dr. Nahir. So the title of the presentation is Relationship Between Life Expectancy, GDP, and Public Health Expenditure in Bangladesh from 1974 to 2019, a VAR approach. Right. So if you could please take the floor. So again, I'm gonna get out a warning. Once 10 minutes is up. Thank you.
Thank you so much, Vinish. So hello everyone, good morning. My name is Samsun Nahar. I am a graduate student at University of New Mexico in the Department of Economics. I'd like to thank you, Nepal Study Center, for organizing this amazing conference and giving me opportunity to talk about our research, which is the relationship between life expectancy, public health expenditure, and economic growth in Bangladesh. I have a co-author on this research. So let's talk about a little bit about the motivation why we are doing this research. So nutrition and health play a substantive role in economic growth. Health care is another important development issues right now facing in the world. And the long-term effect of health on economic growth can be measured in more general context of the relationship between economic human development and economic growth. So therefore, health expenditure is considered as a capital of human development because it protects us from the downside risks of health. And spending on healthcare is an investment, especially for the early childhood child development. Because it's therefore improve life expectancy and it ultimately improve the economic growth in a country. So life expectancy in this way will be an important outcome to measure the health quality. So the question is, how much a country should spend on healthcare? So according to World Health Organization, a country should spend 5% of its GDP on healthcare. So in this perspective, Bangladesh is far behind. Because in 2018, Bangladesh only spent 2.3% of health expenditure as a share of her GDP. And the main source of the health expenditure in this country is the public health expenditure. And so as a developing country, Bangladesh has some issues with lower health outcomes and lower life expectancy because of infectious disease, child and infant mortality, and maternal mortality. Undernutrition is another problem. So which motivates us for doing this kind of this research. There are some previous related research in this context. Like there is some research finds some significant correlation exists between healthcare expenditure and life expectancy in both developed and developing countries. And some research found that public spending on health can promote life expectancy. Also, both public and private health expenditure are very important for improving life expectancy. There are some paper found the positive relationship between public per capita health expenditure and per capita GDP. So, but there are some differences between this healthcare system in developed and developing country. So our research question is what is the dynamic causal effect of public health expenditure and economic growth on life expectancy in the context of Bangladesh and over the period of 1975 to 2019. So to our knowledge, there is no research on this issue in this country. So to address this research question, we collect data from two sources, World Development Indicator and Bangladesh Bureau of Statistics. So for life expectancy and public health per capita GDP, we collect data from World Development Indicator, and for the per capita public health expenditure, we collect the data from Statistical Yearbook of Bangladesh, and we calculate the per capita public health expenditure. So, sure, why it's not moving? Okay. So here are some descriptive statistics for public life expectancy, public health expenditure, and per capita GDP. If you see this graph, there's you can see the historical trends of these variables in Bangladesh, and we can see from the first graph the life expectancy increasing over time. Per capita public health expenditure also up and downs between some year, but the overall trend we can see it's increasing. And for the per capita GDP, we can see it's increasing over time. But the last decades, we can see that it's increasing almost 6% rate. So with that, our empirical model we use the Newhouse model to see the impact of public health expenditure and GDP on life expectancy. So here, life expectancy at birth in tier T and per capita public health expenditure on health in year T and GDP in year T, and this is the Euro term. So going to our main model, we do a little bit some test because we are using time series data. And so we want to look at if there is any stationarity between our series. So we use two different unit root tests, augmented decay floor and Philip Parent's unit root tests, and also without trends and with trends. We use AIC criteria to select our optimal lags for each series. We can see that almost all of our variable are almost all of our variable have unit root in the level form, except for the Philip-Parent unit root, and without trend, we can see that life expectancy is not stationary in the level. But overall, when we take the first references, we can see that all of our series are stationary. Especially for the augmented decay floor, we can see that all of our series are stationary. So now the good thing will be if our model is co-integrated or not. So we run two different kind of conjugation tests, Johansson conjugation test and autoregressive distributed lag model bounce test to see if there is any correlation exist. Conjugation exist. The null hypothesis is that for Johansson conjugation test is that there is no conjugation, and we found there is two conjugating equation exist in our model. So which gives us there are some long run relationship between our variables. So also for the autoregressive distributed lag bounce testing, the null hypothesis is that there is no relationship among the variables. So for this model, we use the AIC criteria for the optimal lag selection. And we found that our AP statistics are greater than our critical value of I0 and I1 regressor. So which means that there are long run relationship exist in our variables. So the basic model we run, the ordinary least square model.
Inform you have less than 5 minutes. Thank you.
Okay. So we found that the per capita GDP have a positive and significant relation effect on life expectancy, and we cannot conclude from our result that public health expenditure have any significant impact on life expectancy. So the ordinary least square model have some issues with serial correlation problem, endogeneity issues, like omitted variable bias, because there are some other variables which can impact on the life expectancy other than public health expenditure and GDP, like the availability of physicians or hospital beds, and also environmental pollution and other issues. And there are some reverse causality, because life expectancy can cause public health expenditure and economic growth. So as all of our series are stationary, we co-integrated, we use fully modified OLS model to avoid these issues. So our fully modified OLS model indicate that there is a positive and significant effect of public health expenditure and GDP on life expectancy. So this is the long-run relationship we have. And now the time to look at the short-run relationship. So we use the vector error correction model, and we can see that there are some short-run causality among life expectancy and public health expenditure. We also run pairwise Granzer causality test, and so the null hypothesis is that the one variable cannot Granzer cause the other, and from our results, we can see that life expectancy can Granzer cause public health expenditure, and public health expenditure can Granzer cause life expectancy, and life expectancy can Granzer cause GDP. But we cannot find any evidence that GDP can Granzer cause life expectancy. Public health expenditure can Granzer cause GDP, and GDP can Granzer cause public health expenditure. So with this, our fully modified model, we conclude that there is a causal long-run relationship of health expenditure and income on life expectancy. And from our pairwise Granzer causality, we cannot find any, so the predictive power of income on life expectancy is not significant, but we found there is a Granzer causality among life expectancy and public health expenditure. So there are some, so with that, the policy implication will be for Bangladesh, as Bangladesh are the economic growth or GDP are increasing over time. So it's going to be a good idea for Bangladesh to invest on health to improve the overall human development through life expectancy, and which it's ultimately improve the economic growth in this country. So there are some limitation. We don't have right now the physicians and hospital beds information and some environmental variables. So this is our very preliminary work. So so the next work we are thinking about collect this information and run the model to get some better results. So yeah, so with that, I want to conclude my presentation. And as I said, this is a very preliminary work, so any question or comments will be very helpful for us. Thank you.
Thanks, Samsun. So we have the last presenter for this session. We have Tejeswar Karkora, and the title of the presentation is Role of Women in Achieving Household Food Security in South Asia. So please, Tejeswar, take the floor.
Yeah, I'll just share my PPT. 1 minute. I'm not able to share the screen. Let me just see quickly, maybe.
Do you have the green button that?
I see that, but it doesn't say. 1 minute. Let me just click again. The share screen. clean desktop one. Or I'll just present it maybe if it is not visible, like if it is it has a problem. Is that okay?
Okay, yeah. Please.
Let me just open it instead of wasting the time. Hello everyone. I'm Tejeswar Karkora. I'm a researcher fellow in Kalya Siddharthi Children's Foundation in Delhi. But this particular research paper I will talking about, which was a part of my PhD research work. I'll be talking about the role of women in achieving household food security in South Asia. The estimate population in India around 1.2 billion, and around 72.18% people stay in the rural villages and largely rely on the agriculture for their livelihood. But still, India directly or indirectly faces the social evil like hunger, malnutrition, which spread all over the rural areas of the country. And still, there are like 300 million people go without 2 square of meal in a day. So food security is a crucial issue at the national level, and the role of women in the process of food security is one of the important concerns. The household food security is identified generally vulnerable group like women, children, and elderly, where women are more vulnerable than others. And the study shows that the half of the rural women population is responsible for the world food production, around 60 to 80% food from the developing countries. They're exclusively responsible for the marketing, handling, storages, processing of agricultural produce in their region. But still they are vulnerable in various aspects. For example, they have a constraint in their household, like lesser access to the land, to credit, to education training for better agricultural production. And there are some studies that shows that income in the hand of women is much more better than the income in the hand of the men, because if a woman is economically independent, then their family, the contribution to their household food security and the child nutrition is much better when a man is the head of the household. And so without the consent of women, the aim and objective of the food security cannot be achieved. And this study tried to see the level of awareness women have regard to the food security program in rural area and how they address the issue of food insecurity. In the literature, normally I try to look into 3 major concepts. One is institution, inequality. Second is the vulnerability, especially the capability and entitlement. Third one is the food security, different kind of provision. And in the literature, I try to see the world scenario, then the Indian scenario, then the state scenario, and then within the household, how it works. Coming down to the framework, where I try to capture the contextual factor of the household, which is social condition like sex, caste, and education, decision-making ability within the household and household outside the household, economic condition, which is income and land holding. So this contextual factor of the household directly linked with the gender vulnerability. To capture the gender vulnerability, we have to see the access to the food and resources, utilization of food and resources, role in decision making within the household and outside of the household, which help us to capture the gender vulnerability, which means the vulnerability between the men and women, and which directly impact on the food security status of a household, which means availability of food and access to the food. And the contextual factor of the household directly linked with the coping strategy that the women use to maintain the food security in the household, which is access to the institution like self-help group, public institution, community-based organization, NGO, market, and credit. And there are other livelihood adoption like farming activities, collecting food from the forest, processing and preserving the food. So, and the objective of the study primarily to examine how women perceive food security in their rural household, to study the major concern of the women in rural household have with regard to the availability of food and access to the food, to understand the type of institutional coping mechanism that the women use to address and access to the food, not for themselves as an individual, but also for the household. In the methodology, the present study was conducted in Rayagada district of Odisha. Majorly the population Rayagada is tribal and is declared as one of the 13 primitive tribes in the state. According to Planning Commission report 2005, Rayagada district comes under the 55 most extremely affected district in India. The tools and techniques that I used for the study was semi-structured interviews, case study, participant observation, and focus group discussion. Secondary data also collected from the government report, book, and research articles. Sampling where the household were selected purposively from the adult women of the household, 2 nearby Gram Panchayat and 2 faraway Gram Panchayat from the district headquarters were selected to conduct this study. 10% household, total 235 household were randomly picked up to conduct this study from below poverty line category. Directly, I'll go to the findings. The first objective where I try to see the household food security, understanding the women perception. So the study shows that the demographic profile of the household shows the relationship with the vulnerability. And though this region is a backward region in India, so the demographic profile and the backwardness of the region shows completely, it shows the vulnerability within the household in that particular region. Secondly, the food insecurity and poor economic condition lead to the vulnerability among both men and women. It's not only if the household is poor or if they are not economically not strong, then it impact all the family member of the household. In the FGD, some women say women have to have multiple works at the home, but still take the burden to work outside because her support for the family member is more important. Otherwise, they will die with the hunger. So the work pressure of women put more burden on them and make them more vulnerable. And next one is like the male head of the household always take the decision in the family, and women generally play a support to the male in the household in all the decision. There is a gender disparity lead to the lack of access to the food by the women in the household, and the study shows that the higher level of vulnerability are associated with the lower consumption of food within the household. And women have, particularly in this region, women have a different cultural based food restriction while performing the religious activities. So in Orissa, there are 13 major festivals. So women has to do all the 13 festivals and go without the food. And at the same time, it is one kind of coping mechanism that amount of food would be shared to the other family member. And during the food scarcity in the household, the women ate smaller meal, they ate some food that they didn't want to eat due to the food insecurity. Coming down to the second objective, where I try to see the household food security issues and concern, it looked into two major line. One is issue at the household level. One is the variation of food pattern depending on the season. So because this area is a tribal dominant district and far away from the government policies and program, so they depend upon on the seasons because they live in the mountains. So as per the seasons, they consume the food. Secondly, the cost of the food is a major determining factor for the household pattern, because the food nowadays we can see the prices are going up. So it's very difficult for some household to buy the food product for their own household. And thirdly, primarily the adult household member skip the meal, and which is more genderly defined, because always it is the women who would skip the meal if there is a food insecurity in the household. And there is a limited food diversity in the food basket in their household. Secondly, the food security concern at the household level primarily relating to the household economic condition, access and availability of food. So depend upon the affordability. If there is a low income and the problem in accessing to the public distribution system, it means it impact on their food security system in their household. Secondly, access to the less access to the work, because since those areas doesn't have more work, and then people that depend upon either the MGNRGA or they depend upon the forest to sell some product at the market. If they don't sell it, then they go in hunger. Third one, the last one, in my objective, I try to see the coping mechanism to tackle the household food insecurity. So there are two kind of coping mechanisms that the household they use to come out from the food insecurity. One is informal coping strategies. In spite of all economical condition of the household, they adopt they either borrow the money or their traditional pattern to preserve the food, depending upon the forest, depending upon the kitchen garden. That is the informal coping mechanism that they adopt while there is a in household.
Tejeswar, so I just wanted to remind you have less than 3 minutes. Thank you.
Yeah, no problem. Yeah. And the formal coping strategy is they access the institutional safety net like PDS, like public distribution system, Anganwadi Center, midday meal scheme, or MGNRGA, Mahatma Gandhi National Rural Employment Act, and pension. But in PDS, the ration from the PDS every month was not sufficient to manage for a month due to the large family member, and they get only 25 kilos of rice, which is not sufficient. And due to only they have rice, so they finish the rice within few days, and which is not sufficient. Like 25 kg of rice is not sufficient for a whole month. And they have a lack of money also. Sometimes they don't have money, so they cannot afford to buy the affordable rice also at the same time. And there is a corruption in the PDS at the same time that I observed doing my field work. Coming down to the Anganwadi and midday meal scheme, this is another way they tackle the food insecurity, because the children will bring the food to their household to share with the other family members so they can eat. But there is a caste play also an obstacle in terms of access to the midday meal scheme and Anganwadi. Then the pension is another coping strategy that the old age people, widow, or differently able people they use, but the amount they receive is not sufficient for the whole month. Coming down to the conclusion, the role of women are more important in the process to save the household food security. Intervention should take in consideration the caste and social dynamic. And the policy intervention should be more women-centric to tackle the food insecurity situation in the society. It is high time to recognize the role of women in the development of household food security. And women are the major contributor to the household food security, and in other hand they are deprived from the economical right. So the right over the land that will enhance their status, it will help the women to engage more with the farming activities to produce more. So this study help us to understand the institutional mechanism of the food security and concern of women regarding to food security in backward region of the country, especially state like Odisha. And this gives us a brief idea about the coping mechanism that adopted by the women in rural area during the time of food insecurity in this particular region. Thank you.
Thank you so much. I apologize, for some reason you're not being able to share your screen. So what I'm going to do next is we'll take about 5 minutes. I know we're running out of time, but we'll take about 5 minutes to allow the presenters to answer their questions. So we have some questions for Dr. Dulal. So percentage of Dalit in your sample seems very low. And the second question is, Newar is lumped with upper caste. Maybe the title of upper caste may not be that appropriate these days, right? So maybe you can simply change it to Baun Chetris. And so education itself can be driven by discrimination, right? So, and the other question that we have is, you may want to look into this is more of a suggestion, you may want to look into a non-parametric method of decomposition. Right, so if you want to answer some of these, that would be great.
Yeah, sure. When it comes to the sample size, the lead, I also, when I saw the result or the percentage fraction of Dalit, I was a bit surprised with that, but I have, because this is the panel data, and when we created panel data, maybe because in that process, we missed some of the observation related to Dalit, but I have to double check that. I can double check the data, Dalit data. The next question was, I believe not including Newar in that. We can add one more category where we can include only Baun Chetri and Newar. We can do that. Thank you, Dr. Alok Bohra, for that.